So good afternoon, everyone. Welcome to the task force members. We'll have a few more of them joining, and welcome to the public, and thank you all for keeping up with this. We've got a lot of good work ahead of us, a lot of great work we have done. Can you hear me okay? Great. I'd like to start the meeting by first recognizing not just the folks who are here from the public and the task force members, but some other individuals who are doing some things behind the scenes to help us keep this work moving and probably equally as important, keep it funded. The county has continued to demonstrate a significant commitment to this work. We're not trying to embarrass people, but we think it is important to make sure that the community is aware of community partners that are helping to keep this moving forward. County Commissioner John O'Grady and his colleagues on the commission, they've increased their level of support for this process. And behind the scenes, I'd like to recognize Director Anthony Trotman and his team in the county. They've been working behind the scenes to make sure they identify the resources. When you have a limited budget, you've got to work with what you've got. And as a team, they figure out how to stretch the dollars and do it in a very effective way, and so we're very appreciative of that. Also want to thank Health Commissioner Teresa Long. I know she's going, what, is it the mumps again? Well, it's probably that too, but talking about working within budgets, she and her team are also working and have identified a way to redirect some dollars toward this effort. I think to the tune of, I don't know how much, so I won't say, but we appreciate that effort. And of course, we continue to be very appreciative of City Council, led by President Ginther. I don't think he'll be joining us today, as they are also working with the Columbus Foundation, have continued to identify funding. So there are dollars at work behind the scenes, and there are people at work to make sure that we're able to keep this moving along, and we're getting pretty far down the road. I'd also like to take a minute and remind everyone and thank you for the community engagement that's taking place. So we've talked about how there's an ongoing effort to include the community. We're having community-focused focus groups and workshops with key stakeholders, as well as presentations about the task force. I think that's one of the other areas that Dr. Long, she keeps getting pulled into, is going out and speaking and talking about not just the mumps, but what the work we're doing here. But in addition to that, neighborhood groups, the March of Dimes, and the Chamber of Commerce, among others, are some of the groups that have been engaged in this work and providing their input, as well as getting some understanding of what we're trying to deal with. The 90-minute workshops or focus groups, they're designed to get in-depth input from the community and key stakeholders. They've been scheduled with program leaders and their frontline staff, and educators and clinicians as well. Hopefully, all of you were able to review the video summaries of the first 4 meetings that were sent out as part of your briefing materials. I think the videos were very informational. They really bring to life a lot of the ideas that we've discussed. And for instance, some of those are the challenges that are associated with a term we're all becoming very familiar with, social determinants of health, housing, transportation, employment, very real and impactful in the lives of many of the folks in our communities. Reducing pregnancy among our young people is another area and issue that continues to surface in this regard, and the work that it will require, focused commitment to not just education, but empowering and supporting young girls and boys in our neighborhoods with the right information and the right choices, or the ability to make the right choices. And as we think about neighborhood-focused strategies, we need to continue to engage residents, and this is important, not so that we just inform them, but they are informed in such a way that they own the solutions and own the implementation and execution of those solutions. So that's an important partnership. As good as the videos are, we really want the task force members for you to hear for yourselves. And so we not only invite you to continue to attend these sessions, but there's a sign-up sheet coming around so that we can be even more proactive in giving you the opportunity to sign up. You all have very busy schedules, so we thought this might be a way for you to see what's available and the dates, and make a notation of the ones that you think you can attend. So look forward to seeing some of you there. With that, I'm going to turn it over to my colleague Mike to keep us moving.
Thanks, Donna. So that's it's a good way to kick us off. While we can look at all the data and all the numbers and all the charts that we have, and it's important to get benchmarks, nothing is more important than hearing from people in their own words. And I know a number of you have been to these community sessions, but I encourage more of you to attend at least one, if not a couple, if you can. Those are very important, and it's pretty moving to hear people talk about what it is that we're dealing with. So today's agenda is behind tab 1. I think most of you have it here. We have lots to cover as usual. Similar to previous meetings, we'll have an opportunity for small group interaction. We'll get there soon. At our last meeting, we considered the importance, as a reminder, of reducing smoking in our community as part of our strategy to reduce prematurity and sleep-related infant deaths. We also discussed the importance of prenatal care, particularly as an opportunity to assess risk and connect women, and the need to have a systematic approach to provide evidence-based systems and supports, such as home visiting to women before, during, and after the pregnancy, particularly those women who are at high risk, and the importance of that. Today will be the last of our content-specific meetings. At our next meeting, we'll take a step back and we'll look at how different communities have successfully pulled the pieces together to reduce infant mortality in certain areas. As part of this process, we've engaged the Kirwan Institute to lay out data by neighborhood, both challenges and assets we have available. These data will be part of the May discussion so that we can use other community experiences and our own data to help us begin to pull this together and put packages together. And then finally, in June, we'll spend time talking about our plan and our recommendations. But back to today, we're going to build on the work that we've done so far and continue moving along the life course and focus on very specific clinical interventions that prevent prematurity, and also on the opportunities to reduce sleep-related infant deaths, which is certainly a leading cause of preventable infant mortality. Both key opportunities highlighted by our key driver diagram, which we're going to see here soon. Maybe. Maybe not. Commissioner O'Grady and Dr. Allen will start us off by talking about their work on Ohio Better Birth Outcomes. I have to say that slowly. Better Birth Outcomes Initiative, which is an initiative established to foster collaboration to reduce infant mortality. Here we are, we're getting there. We'll then hear from Dr. Jay Iams, who will be talking about, thanks Jesse, talking about clinical interventions to prevent preterm birth and opportunities for our community to systematically ensure that women who can benefit from these interventions are able to have access to them. But before that, we're pleased to have Dr. Danielle Larac, who I just spoke with a few minutes ago, here with us from New York. She'll draw on her experience to highlight additional clinical issues for improving prenatal care and reducing sleep-related infant deaths. Task force members will end the day with a tour of the NICU unit here at Nationwide Children's. And if you've never been there, you're in for a treat. We'll learn more about the NICUs here and across our community and what they're doing to ensure the highest quality of care for these teeny tiny little babies. So with that, I'd like to turn it over to our Commissioner John O'Grady and to Dr. Allen. Gentlemen?
Thank you, Mike. You know, you turn it over to me after talking about teeny tiny little babies, one of which I was never. But I'm extraordinarily happy to be here today, and I've been blessed and very honored to be a part of this task force over the last several months. I was actually the youngest of 12 children, all of whom were gigantic, believe it or not. My mother is a saint, and I am the father of 4. So I think you can imagine that nothing is more important to me than family. We have just a few minutes this morning to talk about the County Commissioner's investment in the Ohio Better Birth Outcomes, so I don't want to waste time. When I first got involved in the Ohio Better Birth Outcomes in 2009, I was shocked by the infant mortality statistics, and our discussions within this group have enlightened me even more. OBBO is a 5-year, $7 million commitment from the County Commissioners, and the initiative has aggressive goals to reduce the infant mortality rate in Franklin County by 2015. As we look at solutions for our community, a collaboration and cooperation between OBBO and the Greater Columbus Infant Mortality Task Force is the right approach. By linking OBBO and other initiatives to the work of the task force, we can leverage existing programs and build supportive community resources around them. Far too many of our neighbors have experienced the horror of losing an infant, including my friend Nathan here. And these statistics aren't consistent with our community's values, and I'm proud to be a part of the efforts that help to save the lives of these babies. I'm going to remind myself of something I tell myself all the time, and that is nobody wants to hear a politician or elected official talk except for the politician or elected official that's talking. And so at this point, I want to turn it over for all the substantive information to my good friend, Dr. Steve Allen from Children's Hospital.
Thank you, Commissioner O'Grady. It's Nationwide Children's Hospital is just really pleased with the support we've gotten through many community partners throughout this initiative that we've had to try to decrease the incidence of infant mortality. And we're very fortunate. In your packets behind tab 2, you'll see a few slides that I have just to give you a very high-level overview of this initiative that the Commissioner was referring to and some of the very initial work that's gone on with that. As both Michael and John had mentioned, the Ohio Better Birth Outcomes initiative that was started in 2009 and was kicked off in collaboration with the City Health Department as well as the other health systems in town to prevent premature births, believing that there's just a big impact that we can have in our community. Underwritten by a substantial investment by the county and really combining a number of resources in the city. As the Commissioner mentioned, we had a number of goals, as you'll see on the next page. One was just an access problem. When we first tackled this, we were somewhat chagrined to find the fact there just wasn't enough slots in obstetricians' offices in order to provide prenatal care to high-risk women. So that was one of the initiatives we had, and I'll show you some data on that. Another one is to have effectiveness in decreasing the prenatal birth rate so that it decreased the number of neonatal intensive care unit days that these children had. And we have, since Nationwide Children's Hospital goes at risk for all these children, we have a way of being able to count all of them regardless of where they're cared for. And then ultimately, obviously, as the goal of this group is to decrease the infant mortality rate. So we have 4 specific initiatives that we've tackled. One is the Teen and Pregnant Clinic. Second one is, which we talked about at the last task force meeting, the Nurse Family Partnership Program. It's one of the visitation programs, but it's one that's been shown to decrease the incidence of prematurity in high-risk women, as well as decrease the incidence of child abuse. Progesterone Promotion Project, of which you'll hear more about the scientific background of that from Dr. Imes here in a moment. And then Safe Sleep Standards. Many of you may remember a Back to Sleep initiative that was nationwide a number of years ago, had a tremendous impact on decreasing the number of sudden infant unexplained deaths. Unfortunately, some of the learnings from that have been kind of lost, and people we find are back to using old unsafe methods. So this is a community-wide initiative to educate new parents, particularly, about how to better provide better, safer sleeping environments for their children. So the next page just shows you a couple of early data on some of these impacts. One is prenatal slots. As you can see, we really didn't have, felt that we didn't have enough of them, and starting in 2009, we started to work with the other healthcare providers in town to open up slots for women who otherwise wouldn't have access to it. As you can see, as of last year, we had a substantial increase in the number of those slots. We still need to do a better job of providing access to prenatal care to these women, but I think we're on a good trajectory with this. Then the second one down there just shows what the total number of NICU days of children who are in our managed Medicaid population. As you can see, we've had a nice steady decrease in that. Some of that has been from some community efforts to decrease the incidence of prematurity, some of which is just to the incredible improvement of looking at ways to better provide care for these children where we get better outcomes but shorter utilization. And those of you who will go on the tour with Dr. Shepard later and his colleagues will have a chance to see what some of these innovations are, some of which have gotten tremendous national visibility. In addition to those initiatives that I talked about, we have some others that you'll see on the last page of the slides. Breastfeeding has been shown to have a very positive impact on children, whether they're born premature or not. We now have a standard through all the Central Ohio hospitals to not only promote breastfeeding, but provide ways to make it easier and reduce some of the obstacles to women who are willing to breastfeed their infants. Through a number of efforts, we are enhancing reproductive health planning and options for that, particularly in the teenage population. One of the things that plagues Franklin County, as it does every other urban and rural community in this country, is the increase in the number of women who are addicted to narcotics when they give birth. This has obviously a negative impact on those children. We have clinics where we try to better manage these women and the negative effects it has on their children over a longer period of time. And then I'm happy to say that all the partners within Ohio Better Birth Outcomes are fully engaged with the activities of this infant mortality task force and are committed to doing what they need to do in order to implement the recommendations that come out of this task force. So thank you to Commissioner Grady for allowing us to have the support to do this, and thank you for letting us talk about our program.
Thank you. We appreciate the update and the work that's being done. I mean, I guess one of the things to think about is that there's a lot of efforts already underway, and as a part of this, we're going to capitalize on initiatives already underway, as well as create new initiatives. And to that point, I'm going to take just a moment, and I'm going to ask Michelle Heritage to share just briefly something that occurred during our meetings here in terms of partnerships. My folks are going, what is she doing? That's not on the script. It'll be okay. We've got heart specialists here, right? Oh, for babies, sorry. Michelle, would you just take a moment and talk about, because I think this is a great example of how when people who don't know each other come together around an issue, and how resources that you never would have thought, to connect, they actually do connect. So go ahead and tell that quick story.
We had a great thing happen last time we were at the Infant Mortality Task Force. We were getting some presentations on some various programs that are holistic care programs for folks to reduce the incidence of infant mortality. And one of the programs that was presented has this rolling semi that has a prenatal clinic and has an extraordinarily good program that's holistic and has a very low infant mortality rate. And so I said to Donna, gosh, that was really fantastic. One of the things that we are not able to get at our new shelter, which will have at any one time maybe 200 women in it, and was prenatal care. And the reason for that was the federally qualified health center just didn't feel comfortable, that's going to be in that new building. They just didn't feel comfortable doing prenatal care because it's kind of a high-risk business. And so Donna connected me to Karen Morrison at Ohio Health, And Karen said, let me connect you to the right people at Ohio Health. And we talked and got together, and they said, let's check to see if we can do this. And they got back and said, we can do it, but you're going to need to build this special kind of plug into this new building. And so we sent that out to our contractors, and they said, we can definitely put that new plug in this new building. And so we will now have prenatal care, social workers, an OBGYN lab that's on site, sexual health, and contraceptive services available to these women that they would not have been able to get before. So we're super excited, and it was just an absolute fantastic connect.
And so that I think is a real-time example of how not just the networking, but the information exchange. And once people get it and understand what's at risk, but also what resources we have in the community, natural connections will come to reinforce work that's already being done by organizations like Ohio Better Birth Outcomes. So I just wanted to highlight that because there's evidence we're already starting to move in the direction we want to go in. So today we're going to hear more about a few clinical interventions. I shouldn't say more, but we're going to get a little clinical now. So, and these are clinical interventions that can contribute to a reduction in preterm births. We're going to hear from Dr. Jay Imes, a national expert. He lives here in our own backyard. He is an emeritus professor of obstetrics and gynecology at The Ohio State University Wexner Medical Center. His clinical and research interest is in the prevention of prematurity, and his work has been widely published in the field. He has also served on many national expert committees to prevent prematurity, including the Institute of Medicine Committee on Preterm Birth, and he's currently the obstetrical lead for the Ohio Perinatal Quality Collaborative. Dr. Imes has been actively engaged in our task force process through his participation on a physician's work group that meets every 2 weeks with Dr. Long and Dr. Kelleher as a resource for our work. I know you think it's just Mike and I being just naturally individually brilliant. Not the case. And we're most pleased to have Dr. Imes join our full group today. So, Dr. Imes, please welcome him.
Now I need to figure out these slides, right? Other. And this one and start the next one. Thank you for that nice introduction. We're going to catch up to these. There we go, right there. I'm essentially going to tell you the story of my own career, which has been successful in terms of number of papers published and whatnot, and totally unsuccessful in prevention of prematurity. So I think we finally may have it right, as I have achieved emeritus status. Prematurity is an under-recognized leading cause of infant mortality. When the CDC puts these statistics together, as they did in this paper, and relates the proximate causes to the root cause, birth defects and prematurity come out pretty much neck and neck at around 33-34% each. And so when you look at prematurity that way, we think of all the wonderful things that are done with premature babies, and they do wonderful things here in this building. But those babies are not necessarily healthy, and we don't hear the stories of the premature babies who died either before birth, in labor, or after birth. This chart, the dark bars show you where deaths occur and gestational age is across the bottom. And you can see the dark bars account for about a third of the total number there. So this really was a wake-up. The CDC didn't ever put the data together quite like that, and obstetricians until recently thought of themselves as responsible for bringing a live-born fetus into a newborn baby, and then after that it was, we did fine. It's the pediatrician and family doctors and nurses. And it's really our role before delivery to prevent one of the leading causes of infant death. So we have this medical model that I said has essentially been what I've been doing my whole career here. It's essentially Band-Aids though. And at the bottom, the thing that really is going to work the most is what you've been talking about already. We're going to talk about some effective interventions that can happen right before a premature delivery or during labor or a little bit before that during pregnancy that have merit but that are still nevertheless Band-Aids. They back up to say they're tertiary, secondary, and primary according to really how much weight they should get. Tertiary doesn't really affect the incidence. So secondary things, finding women at risk and getting rid of the risk and making things better. That's been my life, and I've had some participation in all of these things from about the early 80s until now. The first thing we looked at was uterine contractions. We tried to find them and make them go away. That didn't work. Infections came along, and we tried very hard to find those and make them go away and make prematurity disappear as a result, and that did not work. Nutritional deficits are certainly associated, as are infections and contractions, with premature birth, but finding those nutritional deficiencies has not helped in randomized trials. Calcium, fish, eating fish maybe a little bit, but taking supplemental omega-3, no, more protein, more vitamins, vitamin C and E, all those things, essentially not effective. These kinds of studies take several years each, and they pretty much occurred in this general sequence. Detection of short cervix was associated with increased risk, and to some degree trying to fix that, making the cervix stronger, we thought stronger, with a suture, has had some benefit, but not nearly what we might have thought it would be. And social support has been avidly pursued because it seemed to make sense. Most of the studies there have been disappointing. Some studies in adolescent black females in particular, teen girls in North Carolina, were successfully helped to have a lower risk of premature birth. And there are some other social stories like that of more recent origin, but that has not been as effective. During pregnancy now, this is not talking about beforehand, this is all finding things during pregnancy. And more recently, the opportunity to try to prevent risk in some women by giving them supplemental progesterone, something that pregnant women have a lot of already, has actually, and somewhat to everyone's surprise, turned out to be successful, at least in some. And we're trying to sort through that, and we'll talk a little bit about that throughout the rest of the afternoon. During this period of time, the prematurity rate went up. This is 1996, and it peaks. The prematurity rate starts down at 11% for the United States in 1996, goes as high as 12.8% in 2006, and then it went down. And in both cases, the up and the down, it really was systematic changes in healthcare and practice that did it. The increased ultrasound dating allowed us to properly date women and recognize that there were actually more premature births than we thought. Fertility care helped women and families have babies, but it also conferred an increased risk of twin and triplet pregnancies. And then we began to see an increase in scheduled deliveries after 34 weeks for what were typically good medical reasons that made it very easy to say, well, you know, I delivered somebody last week at 35 weeks because she had this or that hypertension problem or bleeding, so it's really 37 weeks is fine, it's full term, right? Actually, not so much. So that had a good effect and a not so good effect. And as you'll see here in a minute, those things went down when those things were systematically changed, and we're now down to a rate of about 11.5%, basically because of changes in those systems. So who did that? Was it us in obstetrics and gynecology? Participated. How about us high-risk OB doctors, right? Same thing, not so much. Midwives? No. It was the CDC. The CDC, again, in cooperation with a variety of organizations, including fertility doctors, but the CDC talked to the fertility doctors and said, you got to change the way you're assisting fertility. Too many higher order, too many triplets and up, because that's 3 premature babies per 1 pregnancy. Twins, same thing. Half of twins deliver early, 90% of triplets deliver early, and they're not supposed to be early. They're not mature faster. So who did that? The March of Dimes did that. They made a lot of noise, and ACOG and others made a kind of a responsive noise. But essentially, how did they do all that? I want to note that the research didn't do it. They didn't find the key to prematurity. The leadership did it by making prematurity a problem that the March of Dimes cared about. And how did they do it? They publicized the data. They didn't have a new treatment, a new pill or a new drug or whatever. They just made everybody aware this is happening and it doesn't have to happen. And here are the rates. Here are the rates in your backyard, and you can tell where I'm going to go at the end with that. That happened here in Ohio, locally in Columbus and around the state through the Ohio Perinatal Quality Collaborative and other collaboratives. We certainly weren't the only one. But in Ohio, we were a statewide collaborative built around the largest hospitals in the state. And when the two lines diverged there, when the OPQC project around 39 weeks delivery started, is about when the rate of births after 39 weeks went up and the rate of births before 39 weeks, but still, quote, at term, went down. In other words, we traded about 36,000 births, 37 and 38 weeks, for 39 plus weeks. And that saves a substantial number of NICU days and babies, some of whom might even have died. So that kind of systematic, it's not okay to deliver before 39 weeks unless you have a good reason. Put things in place to make that happen, and you see the results of that even now as it's continued. Ohio Hospital Association has an ongoing thing about that, and most of the hospitals here in town have a practice built around that. So that's the kind of systematic change. Antenatal steroids, a Band-Aid really, that we give to women who are about to deliver early so that their preterm baby, expected to be born soon, can do better. Steroids given at that time definitely help babies survive, not only in the short term but in the long term, and avoid NICU days. And they're, of course, not really a prevention. They're literally a Band-Aid at the last minute. If you're jumping out of the plane, here's the parachute that might help you. That's not exactly a successful strategy. This progesterone supplementation approach, as I said, was kind of a surprise. It's been helpful, but it's specifically targeted at a relatively small number of women who deliver, probably about 15 or 20, 25% of the population who deliver early at most, have a short cervix, or they have a history of a previous premature birth, or both. So finding those women is what we're aimed at. The quality improvement approach, where everybody gets together and tries to do it the best they can together and learns the technique of not missing things every patient every time, like industry does. In steroids, in this case, shining the light was first done by Ohio Hospital Compare. This graph showing the rates of steroid use in babies who were born early, who were eligible. The rates went up, way up, when Ohio Hospital Compare said, we're going to publish that. They didn't even publish it yet. They just said they were going to publish it starting in January, and immediately the rates of documented use went up. They went up further when OPQC said the same thing. Turns out hospitals were actually doing much better than these statistics actually say, but we weren't documenting it, so we weren't really sure until we actually did the project. The progesterone project is a little more complicated. Our goal is directly to prevent premature birth and thereby to reduce the rate of infant mortality, especially the rate of early premature birth, which is so frequently the cause of infant mortality. So we have to find these two groups of women, short cervix, which can be done with an ultrasound only, unfortunately, and a history of a previous premature birth. This progesterone medicine that we talked about rather simply turns out to be harder to prescribe than you might think. Finding the right medication for each woman and getting it to her is not as easy as you might think. So that's a struggle, and we'll talk about that a little bit in the discussion section. Our outcomes are the prematurity rate and the associated infant mortality rate, and of course some process measures as well. So who are the women that we're looking for? Well, we're looking for all women with a history of a previous premature birth and women with short cervix, but particularly we're looking for women who deliver before 32 weeks, where that accounts for only about 1.5% of births, but about 2/3 or 3/4 of the prematurity-related or perinatal mortality. These are the most high-risk women of all. High rates of death, very likely to happen in subsequent pregnancies. Cervix is often short in these women, progesterone often effective, and who are they? They're our African-American patients. It happens to everybody, but it happens in great disproportion. As you can see from the bar graph, you can always tell in obstetrics when there's one bar graph of something bad, that's always the African American women in virtually everything, whether it's prenatal care or prematurity or infant death or stillbirth. And that's the case here. The rate is twice as high. So attacking this problem not only attacks infant mortality, it attacks the embarrassingly high disparity rates that we have in perinatal outcomes. The trouble with progesterone, as I said, is that it's a Band-Aid. It's not prevention. It's hard to know how many women are out there. How do we know we're capturing, if we take care of 100 women, is that 50% of the population? Is that 5% of the population that might benefit? We don't really have a good handle on that, so we need to be very aggressive about trying to find that information. These are relatively simple to ask the question about, have you had an early birth before? The OBO project started that way, and that's how we were able to find a lot of those women. But then it turns out those histories are not always quite as simple as we might like, and the ultrasound that's done here is not the fun kind you can get at the mall with the abdominal probe. It has to be a transvaginal scan to see the cervix accurately. And unfortunately, the biggest barrier is you can't just write a prescription after you've found somebody who needs this medicine. You can't give them a prescription to take to the pharmacy and everything will be fine. You have to navigate, how are we going to match this woman's need, her problem, with her payer, with the medication she needs that is not available simply by going to the pharmacy. It has to be much more complicated than that. And who's going to pay for it, and will they pay for the same thing that the last patient I saw paid for? Maybe not. So our ultimate recommendations, and we'll, again, hopefully we'll have a chance to talk with you about these, are first of all to do what's been successful before. Publish the outcome data, our outcome data, for us to see. Make noise about it. I'm embarrassed to say I think Michigan did that and they're ahead of us. That's how they got ahead of us. They made noise. They made it a big deal. How many dead babies are there? That's a very shocking thing to say, but that's how many babies died in Ohio, in Franklin County this year. If we track that, we track the relationship of that to prematurity, to smoking, to teen pregnancy, etc., we can do that. We're doing well on the scheduled birth initiative. We think the right target is no longer 5%, which was a pretty optimistic target 5 years ago. Probably the right figure isn't 0, but it's probably about 1 or 2%. We can publish the rates for multifetal pregnancies. Twins are cute, but they're not really cute. 50% of them deliver early, and they don't mature ahead of singletons. So the rates of twins, if that's higher in Franklin County than it should be, than what's ideal, we ought to know that. So antenatal steroids, as I said, we're doing pretty well, but we can never let our vigilance down there and make sure. And for all these things, there's a racial disparity, and it's always the African American women who are getting half what they need or have a rate that's twice as high. Looking at this data in tables is not very impressive. If you look at the numbers, 16 has the same size as 32, is the same size as 64. But when it's on a bar graph and it's over time, and you look, we started here and nothing has happened, or something has happened, or something's happened the wrong way, graphic displays make all the difference in actually moving people. And ultimately, this is something that needs to kind of arise from the community. I don't want a premature birth. Doctor, am I at risk? I don't want to have a scheduled birth. Am I at risk? I need that ultrasound, or do I? Maybe I don't. Well, some of those answers we know and some of them we don't. But basically, making a lot of noise about this particular project is what we've learned. The medical Band-Aids, so that my career has been built around proving that they didn't work, was basically that. So what's left is the social determinants of health and systematic type things that you guys can do, you at the table can do. We'll just put the little Band-Aids around the edges. So I'll be around for the sessions, and Jesse has, my whatever. Well, contact information. I thought I was more like you're the one who drives where I go next. So I just want to thank Jesse Cannon for prepping me for this particular task. So thank you.
Can you take up some questions? Dr. Imes, can we just impose upon you for just a few questions? I know I've got a couple.
Sure.
I'm not very knowledgeable, so this is what I hear, that there is an increase in the number of induced of induced labor. Is that true, and does that contribute? I mean, I know there is induced because, you know, there's a problem with the pregnancy, but then the thing I'm hearing about is, well, it's more convenient if I have it on this date versus another date. How does that factor into this, if any at all?
Well, I think it does factor in, and I think we've turned the tide around on that. But what happened was that we recognized that we could assess the fetus's health before delivery, and rather than just hope that things worked out okay, we could choose delivery by inducing labor, say for a 34-week baby who was growing poorly or who had tests that said that baby was not going to do well. So that was good. We prevented stillbirths. The rate of stillbirth went down. However, we learned how to do inductions of labor, and doing them for good medical reason kind of changed the culture of labor and delivery and made it possible to say, induction's not that hard. We have pretty good techniques to do induction, and pretty soon we began to think 37 weeks is term, right? We really shouldn't call it term and preterm. We should call it premature. You know, you're not mature when you're 16 or 18 necessarily. You know, 5 kids, a couple of them were, a couple of them weren't. They're all the same age. Well, we switched to age instead of maturity, and that allowed us to feel comfortable delivering babies who didn't really need to be delivered for the reasons that you talk about. That tide has been turned around. Gus Parker led that here in Columbus, and a lot of other people at other hospitals. And I think we're well on our way nationally. The Boomer Esiason comment a few days ago, there was a very quick response to Boomer's suggestion that a player, sports figure, should have his wife delivered early or something. Anyway, that we have to pay attention to that. Yeah. But I think that's one of the battles we're winning.
Okay. Any other questions?
Nathan.
Just curious, this notion of a short cervix. Any idea what causes that? Is it genetic?
Well, when it was first identified as a risk factor, we simply thought it was like basketball. Your short cervix, you know, the game is called having a baby, and you're short, so you can play basketball only very carefully. That's what we thought. Turns out, after 10 years of not understanding things, that short cervix isn't really preterm labor, because that means painful contractions at the end. But the processes that lead up to that make a short cervix, it's called parturition. And a short cervix at 16 or 20 or 24 weeks is parturition in progress. So a short cervix was now recognized as a very slow, or the early onset of a very slow process that goes really fast for those women who deliver, say, between 17 or 18 and 25 weeks, a little slower for those who deliver later, and maybe so slowly that nothing really happens and they deliver at term. That's not the only kind of premature birth there is. There are not short cervix premature births also. Those women typically have painful contractions right from the start. The short cervix group, one of the problems is it doesn't hurt a lot. The cervix is already soft, already very compliant. So when the contractions start, it doesn't really hurt that much. And people ignore it. Women ignore it, and then the care providers ignore it until it's too late.
The causes?
The causes are it's a hard thing to give a short answer to. The combination of environmental and genetic factors that are best described as an inflammatory process in the reproductive tract that progresses very slowly, except when it goes really fast in women who have probably not only the right genetics, but they have the right other environmental exposures. Being raised black in America is the most powerful exposure that there is.
So there again, and forgive the continued questioning, that there again we're at social determinants of health.
Right. Social determinants of health are those exposures. And it isn't a gene, you know, most of us think of genetics as, you know, the gene that makes your skin dark is the gene that also triggers early labor. That is not it. It is the exposure to the environment. And there are lots of different genes that turn this and that on. So it's genetic, but it's not really racially genetic.
Thank you.
Okay, one more question, and then we're going to break into groups and have further discussion.
So, Dr. Himes, thank you. And we're very lucky to have you right here. My question is about asking, could you drive us a little further on your recommendations? Because clearly the ability to publish data, and some of it is able to be gotten. You know that we've stepped up actually because of a conversation with Dr. Allen and Dr. Kelleher to try and have a monthly report. I think yesterday we just issued another one. But again, you made mention that the March of Dimes had such an impact by taking data and then driving it to other places. And I guess my question is, how would you suggest this task force think about encouraging the publishing of data, but then making it data that has action connected to it?
Well, I would take the advice from Arthur James, who moved here from Michigan, and when he was in Michigan attacking this problem. The day that the state released the infant mortality data for the state of Michigan was a big deal. The media gathered round and listened, and they compared one region of the state to another, and especially they compared themselves to the previous year. He came here, tried to do that very same thing here. Ohio Department of Health, where's Karen, put that out, and nobody cared. Nobody, one radio station in Cleveland called up or something, that was about it. Nothing. There was like, yeah, babies dying is, we know that. We're 47th. 49th in African American rates. We have to care about that and make that published. So making it local we need to make a way to make us feel like we could do better in Franklin County. We could make it, you hate to do zip codes, but we could make it regional in some fashion. Of all the babies born at OSU, how many of them lived a full year after that? That would be painful. We would have a low score on that. We deliver high-risk women. But we ought to do better next year than we did last year. And if we frame it that way, we can all do better next year than we did last year. Right now, we're not doing very well because we don't respond to the statistics. So, I mean, I think dispatch editorials are great, but persistence is really the name of the game of put it out there, put it out there.
So let's do this. We'd like you to break into two groups. You're sort of in two groups. So one on this side, one on that side. So, you can move your chairs to come closer together. And we're going to take maybe 10, 15 minutes and have you each have a discussion about, areas, this area. Dr. Gus Parker, Dr. Iams will facilitate the discussion so you can ask more detailed questions, get a deeper understanding. And in particular, there's a handout, I think, on your table about 17P and the 39-week project. And so you can use that as a discussion guide. We don't expect you to come out of this with your PhDs and start practicing. At least we hope you don't do that unless you already started off with one and you are practicing. But it is important to get a little more granularity around these clinical areas and the projects and initiatives that are out there or ideas that we could have. So I'll ask Dr. Parker and Dr. Imes to take different sides of the room, and we're just going to take 10, 15 minutes and have a group discussion with these two experts. A good discussion. I tried to float between the two segments. We didn't get an opportunity to switch sides, but I would like to ask you, one person from the group, I didn't ask you to appoint a spokesperson, that's not necessary, to just share the one of probably many salient points that were raised that as we think about what was discussed that we need to be thoughtful about moving forward, or we need to include in our recommendations, or be thoughtful about moving forward, or even just what you learned that you didn't know before. So I'm going to start with the group that was facilitated by Dr. Parker. Anyone want to chime in on any of those areas?
I can, if I may. The thing that struck me most is how important it was to have collaboration and set standards among the different hospital systems, and that helped to control some of the behaviors. So having standards where they wouldn't allow babies to be delivered before 39 weeks. And just a quick side point for me, you know, I'm continually amazed at how much we know. I'm continually amazed at how much the medical community knows. And that, again, rang true for me. I mean, sitting here, I think we were sort of in awe at some of the things we heard and what they knew. So,
No, good call out. So that was the group that talked about the importance of 39 weeks and the strategies that are in place that or need to be in place, statewide and local. Let's hear from the 17P group and give a little background and what you thought was one of or more of the most critical issues we need to be thoughtful about. Oh, come on. Talk into your mic, or there you go.
Yeah, you know I'm shy of microphones. There were 2 points, education and policy, that we thought were important, along with sensitivity related to when you talk about the disparity and the group that is most impacted by this possible solution, and what are the cultural implications of that, and the need to discuss the impact of 17P and educating individuals about it, and what are the policy needs related to creating it or implementing it as a solution, but being very careful with what type of messaging and communication this has when you talk about African American group and a possible drug-related solution, and how that is really predicated on the amount of education that's provided. And so talking about it as a solution, but also being careful about the solutions and the cultural implications related to it that we must be sensitive to, and thinking through it and talk about its success, but also talk about how does that get implemented and where are the touchy points for it. Education not only to the patient, but to family, and from who, with who, and also where's the biggest bang for the implementation, age, group, how the difficulty of identifying particular groups through short cervix or genealogy, all those other pieces, and how do you do that and do that well?
Yeah, I heard a little bit of that conversation. So you think about culturally and historically, there, you know, a concern may be just a kind of blanket determining that a minority group, an African American, should take a certain drug. Historically in the country, there have been issues around that, and you know, we see we are well beyond that. But I think Dr. Iams did a great job of trying to say, you have a one-on-one conversation, and it's an individual choice and decision after, just as Michelle said, the prospective patient is informed, and given the high propensity in certain communities of premature births where this can be helpful, I think what you're saying is you have to be very sensitive as to how you go about that, and that cultural sensitivity with all groups, African American, Latino, you know, and even women who are not of color, is important, so people are well informed relative to what they're taking. All right, good call outs. We could talk more about this, more to come as usual. Thank you for taking the time. We'll turn it over to Mike to take us to the next phase of our meeting.
So we're going to, we will break back into groups again after our next presentation. We seem to get a lot done as we discuss the information after our speakers. So next we have Dr. Danielle LaRocque, who is a vice president of Maimonides Infants and Children's Hospital in New York. I hope I pronounced that correctly. She's nationally and internationally recognized expert in injury prevention, child abuse, adolescent health risk behaviors, and healthcare delivery in underserved communities. With Dr. LaRocque's presentation, we will transition from our work that is largely focused on healthy women and healthy pregnancies to begin thinking about what happens when the baby is born. Specifically, Dr. LaRocque will highlight issues and opportunities for reducing infant mortality through regionalization of perinatal services, increased breastfeeding, and infant safe sleep. She'll also highlight ways in which New York has already successfully addressed many of these issues. Dr. LaRocque.
Thank you. It's a pleasure to be here with you, and actually it was a pleasure to participate in the discussions. It actually took me back to the 1980s when these discussions were very robust with respect to health disparities and how you implement change within communities using the best science, but also being very attuned to community need and community input. So I really appreciate being here. I also commend you for tackling this, and it seems that in medicine and in other areas we have to revisit the same problems over and over to continually address them. So I thought I'd begin, and I'm going to try to stick to where is Dr. Kelleher. There he is, that he's asked me to try to make this concise because these are complex issues, which is very hard to cover in 15 minutes, but I really appreciated the conversation before. I thought I'd make a couple of comments. One is that if we're going to discuss infant mortality and health disparities, we must do that knowing there are cross-cutting issues that we have to address. Those include, not new to this audience, poverty, access to care, and allocation of resources, which are differential across the various populations that we serve. So I want you to keep that in the background as context. The other issue in terms of complex issue, infant mortality, which relates to mortality in the first year of life. We've been talking a lot about prenatal care and sort of post neonatal mortality, which is within the first 28 days. But there are a whole host of other issues which impact survival in the first year, and we're not going to be able to touch upon all of them, but I want you to be aware of that. The comment on health disparities, which we began to talk about, relates to what? There are many definitions of health disparities, right? The one that I'd like to use is the one that relates to differences that are due to social injustice or unfairness. So that I wanted to set that as the framework for our discussions around that. And yes, there's new science related to impact of differences that we see in populations that may be due to things we have not measured. For example, the whole field of epigenetics and the effect of toxic stress, which I know in pregnancy we say the stress of being African American, as I am as a woman, and what does that mean in terms of my risk? Well, maybe science doesn't have all the answers yet because it hasn't posed the right questions, and so keep that in the back of your mind. So I'm going to go forward. So here, this is a summary, and I'm from New York. I've been asked to share the experience of New York, and if you see on this first slide, and I'm going to keep data to a minimum, you see infant mortality on the y-axis per 1,000 live births, and you see the date there, 1898, right? So, and then the current date, which is 2012 roughly, which is the data that I have up to, it's 4.7 per 1,000. So we've made great progress. But it's due to a whole host of issues that we're not going to touch here, but we have to know that the bulk of those issues are in the public health domain. Okay, that's the bulk of it. And so in looking at community-based solutions, which we'll talk about, I want you to keep that in mind as well. And then we'll talk about some of the things very specifically that we have some science about. And those are the three areas I've been asked just to comment very briefly on, which is the regionalization of neonatal care, breastfeeding, and safe sleep practices, which we do have very good science on. Okay, I initially started this because Kelly, as a dear friend who's doing really important work, asked me to do this, and it took me to a timeline when I started my work in Central Harlem, which began in the 1980s, and I'm going to go over this you know what, I want to make sure that I have the right version here, because I had the long version and the short version of this presentation, and Kelly, I don't want to start on the long version of this. So I'm going to go back here. Sorry, a second, because it looked like I was going to the longer version. Yes, let's go to the short version that I promised you. Okay. So the areas that the timeline I was going to show you was my journey through healthcare from the 1980s on, but I won't digress to that. Okay. So I was asked to look at the regionalization of perinatal care and safe sleep practices in breastfeeding. Again, I'm not going to show you the science in that, but the science in this is quite robust. We know that regionalization of care improves health outcomes. You have in your packet, I believe, the level 1, level 2, level 3. Level 1 is basic care, level 2 is slightly more enhanced care, and level 3 is the highest level of care, and I'll go through some of that with you. And let me start with that. Now, at the bottom, you see that I said community engagement, persistence, and sustained efforts. We have a great effort often in focusing on a problem and maintaining our focus for short periods of times and then being surprised when the problem reemerges. So that unless we have community engagement, I think somebody mentioned that with respect to sleep practices, well, we know back to sleep works, but then attention wanes and then the problem resurfaces. So I think we need to take a look at that. So critical components of perinatal care: access to care for pregnant women and her baby, obvious. Provision of a full range of services within a geographic area, from the most basic to the most complex. So you don't want to have high-level tech interventions for babies who are at low risk. In fact, we know there are iatrogenic causes to issues, so that you really want to match the care for the child to what that child needs. And that's really an important concept. Level 2 nurseries need to be able to transfer babies out quickly, and some of the data have shown us when that's not been done, actually mortality increases because you haven't matched appropriately. And the highest risk kids should be delivered at the centers that have the highest technology, because you have quick access to the appropriate services. So it's the right care for the right child. Okay, and that's important. And designation of hospitals indicating the level of care in terms of where you do that. I'm going to show you that in New York, it was at the state level that you needed to do that, and that you needed to regionalize care at the state level. And it certainly, we had discussions around policy. Those were policy-driven decisions. And regionalization at the 4 levels, which included the regional perinatal centers, which oversees the 3 other levels of care. You'll see here that what's important, and I think a previous speaker mentioned a couple things that I want to touch on. Systematic sort of approaches are really important. I think a previous speaker mentioned that, so that the infrastructure for quality improvement was embedded within the efforts that started in the 1980s for regionalization of care. So it was perinatal networks as well as regionalization of care. And the two, one addressed really access to prenatal care. The second, in terms of regionalization, addressed actual services to the infant once born who needed intensive services or who needed lower levels of care. So infrastructure for quality improvement, we've learned a lot about perinatal collaborative efforts where many of you have heard the term PDSA, which is Plan, Do, Study, and Act, which is that you have to have repeated cycles of doing things to be able to improve that care. So quality improvement is important. Statewide perinatal data systems became really important in terms of regionalization of care because you had real-time data. Okay? There's nothing like real-time data to let you know what you're doing, and the relevant data to know when you have not hit your mark. And that's been very important. We have a regional perinatal center at Maimonides, and we are the RPC, and we look at our data in minute detail on a monthly basis, are able to target our interventions. And then regional perinatal forums, this is a good example of public involvement in what we're doing so that you can extend public health issues to the community and have an impact. Here, I mentioned the regional system in New York was established in 1985, and it led to looking at allocation of resources to availability of highly trained personnel where they were most needed. And that's important because in Missouri there was a study where they looked at the de-regionalization of care, and they found negative impact from the fact that now level 2s and level 3s were really not maximizing the kids that they needed to attend to. And there were disparities in care as well. In New York, we've looked at some of those studies for level 3 nurseries where in fact we were not reaching the women. Yes, in minority communities who should have had access to those services. And obviously, we're affected by major changes in healthcare system. And while we won't have the time to discuss that today, I think you need to be thinking about that as we evolve to a new system of healthcare in the Affordable Care Act, the Patient Protection and Affordable Care Act, which tries to provide universal health care to all populations, something that in this country we have not achieved. So here, requirements, I see, I think most of you know this, tertiary care hospitals, availability of large enough masses so that you have the expertise and also the volume that merits, that allows one to obtain the skills needed, that you have access to the mostly specialized services such as cardiac surgery, and initiate transport within 30 minutes, and of course research capability to be able to then target the areas that you know little about and that you have to invest research dollars. And the requirements for the birthing hospital, I think, are probably known to most of you. So the regionalization, if the message is for regionalization of care, is that we have done it successfully. It is an effective method. The message from New York is it needs to be at the state level so that you really can maximize your efforts, and you need enough volume, and you need quality improvement methodology to continuously improve your outcomes. And you need disaggregation of data sometimes by various groups, either by birth weight category or, if need be, in terms of health disparities, by various ethnic and cultural groups, so that you can decide where you need to target your interventions. I'm going to move on very quickly to safe sleep and community messaging. These messages need to be community-based, because I think you need to understand a community focus to understand why safe sleep, because SIDS happens to be one of the leading causes of death for children under the age of 1. So again, if we're looking at decreasing infant mortality, neonatal mortality was what I was referencing with respect to regionalization of care. Safe sleep is within that first 6 months, the first year of life, and community-based efforts to know that we have effective interventions, which is back to sleep, not back to side, which for a while we were saying it was okay to be on the baby can be on the side, and as well as the back, but we know the data show us that really the babies need to be on their backs. The public health messages that need to be statewide. The other aspect, which I've been very involved in, both in the citywide infant mortality case reviews of children who died as a result of SIDS, and there are different definitions, I won't get into that. It is integrating that into a city's efforts or state's effort at reviewing all causes of child deaths, okay, which is what we're talking about. Most places do not have an all citywide fatality case review or state case review. I would urge that that is one of the fundamental changes that needs to happen to be able to target interventions. And the ARP, which I mentioned here, the Accountability Review Panel, is in New York City for deaths related to any child who is known to our child welfare system, which is an area we're not talking about, which is child maltreatment. Some of the messages I thought I'd share with you. So if you look at the SIDS disparities here, you see the death rate per 100,000 in this time period. You see the Black non-Hispanic rate here is the highest. The Hispanic rate is slightly lower, and the white non-Hispanic rate is the lowest, okay? And we needed to get out into the community. I don't know if you can read this, but it says promising practices for cultural and linguistic competence in addressing sudden infant death. So that if you're going to go out into the community and investigate an on-scene investigation following the death, you really need to be embedded in that community to understand and educate and partner effectively with the community in understanding the risk, okay, and understanding prevention and bring that message of prevention. Here you see another message, which is the Women's Health Line here. It says, in some communities in New York City, too many babies are dying before they reach their first birthday. There was a question of how do you message this? Well, you have to message it, I believe, in two ways. One, universally. Stigmatizing populations is not a good way to do things, okay? Saying that this is a public health issue that needs to address all populations, and then certainly you need to drill down in certain populations where there are higher risks, but you partner effectively with those communities in understanding the cultural context and how those messages need to go. And these were some of the successful campaigns that occurred in New York, And I started at 1898, right? If you remember, infant mortality from there is to say that you've got to keep your eye on the ball. You can't say we've done infant mortality review and health disparities for 5 years and we're done, okay? No, you're not done. You're just beginning. So I applaud what you're doing and to say keep at it. Here you see disparity in sleep position. So data, be data driven, disaggregate the data, take a look. And here you can see New York City, DOH, MH. MH stands for mental health. We shouldn't have to put that because health encompasses mental health. It's community health surveys, which we found, where we did find that 36% of blacks reported putting infants to sleep on their stomachs compared to 11% of other responders. So there was an education gap, so we knew what to target, and we looked at SIDS deaths there also. And if you look here, these are the data that you know, the pre-AP American Academy of Pediatrics recommendation on SIDS deaths here, and you see post the AP recommendations. And then this is the Back to Sleep campaign where we had effective community-based interventions. And what do you see? You see that here, in fact, you start to see that the SIDS rates decrease as you get increases in the percent of back to sleeping, okay? So that these two things are very much correlated, that if you do the campaign effectively at the community level, you begin to see a corresponding decrease in the SIDS rates, which is what was shown in New York City. The last thing, and again, this is 15 minutes going through quickly what we know are some effective things. I don't have to tell you breastfeeding is best, right? WHO, exclusive breastfeeding up to 6 months of age is the recommendation, and yet we do dismal. This is dismal in terms of, but we know the policies that have contributed to that. Supplementation with formula in the hospitals is rampant, okay? It has been a consumer nightmare with respect to representation of formula and giving out of formula to newborns in the hospital. What New York City did is, in fact, through Tom Farley, who is our former Commissioner of Health and a pediatrician, he said he was going to do what's called the Latch On Initiative. And he first did his homework, which was to bring together groups of hospitals who are already on board. And he says, I'm going to target the first 24 out of the 40 or so hospitals in New York and say, who's on? And he got a nice group of hospitals to say, we're on, we're already doing this. Guess what happened? The ones that were not on board and said, how is this possible? We're not on board, and we know breastfeeding. We don't need the data. We know the data about breastfeeding. That's true for breastfeeding exclusive if you can use breast milk for children who are born prematurely, low birth weight. We know that has a major impact on such things as necrotizing enterocolitis. So the data are there for both babies at risk and full-term babies and healthy babies. And so what he began was a slow campaign to make sure that folks wanted to be on the bandwagon of being on Latch On. That's how I got my hospital on Latch On, and we threw out all the formula. Of course, formula is given for babies where there is medical necessity or parent chooses that. We support women's choice for that. But to be at odds with good medicine, which is breastfeeding, was really shameful for hospitals to be at odds with that and to dispense formula in a way that disengage women from breastfeeding. So we had the New York effort was launched in 2012, and I can tell you we've already seen reductions. And in fact, I think this is the way to do public health campaigns, to really say at the highest level. And and this was a citywide campaign, not targeting only the communities where breastfeeding might have been low, and there are disparities there, but to say this is a public health approach. So that has been successful. I wanted to end with the following, which is this is embedded in the discussions you've had around many things. It's not just one thing. It is smoking. It is anti-violence. It's reducing toxic stress. It's looking at issues of poverty. It's looking at issues of access. And so what we did was in New York, there was a very hefty campaign called Take Care New York, which addressed the major issues around adult care and had one issue around children's care. We went to Tom Farley, I did, and others, and said, we want to focus on children's issues. We applaud all the other issues with respect to adults, but we want to focus on children's issues, and we developed children and youth agenda and work group proposals. And this was raise healthy children. We knew about teenage pregnancy rates, infant mortality rates, the disparities in breastfeeding rates, and we know that we have done community health surveys throughout, which are really critical. And these are the core indicators for the adults, which is promoting quality of health, free tobacco. You talked about physical activity, health hardy, HIV, recognizing and treating depression. We haven't talked about mental health and its impact on women's health during pregnancy, reducing the risk of alcohol, preventing cancer, raising healthy children, which really targeted only teen pregnancy, which was important, and making all healthy neighborhoods. And we expanded on children's issues, which had to do with breastfeeding, early childhood vaccination, obesity, asthma, youth smoking, drinking, HPV vaccination for those 9 to 26, teen pregnancy, ED visits for mental health, behavioral conditions, and violent victimization among youth. So it gives you the idea that the approach needs to be comprehensive. There's not a single bullet. It's comprehensive intervention at the public health level, then drilling down in communities that need targeted interventions, which we still need. This is an example of one of those, since this is we are in the 21st century, we should be using technology to interact with our communities. This is an effort that you could download a teen app that gave you easy access to reproductive health services without barriers that teens can download onto their little phones and click where they can have reproductive health services, at the flip of a switch or whatever it is. So here you see that I joined Tom Farley in this, and we did it at one of the community-based health centers. And we have been successful in reducing the teen pregnancy rates in New York, but there's still 17,000 pregnancies annually, and 87% to teen pregnancies, and 87% of them are at least on the surface unintended. And these are our disparities. While you applaud us in New York for having addressed health disparities, we're not done, okay? We're not done. And if you look here at the green line, this is non-Hispanic blacks, we still exceed the lowest group here, which would be the non-Hispanic whites at 2.7. So the disparities do persist in New York City as well. I think they are largely due to the social and economic disparities that we see. And yes, there are some epigenetic phenomena that we need to look at, and the science needs to guide us as to where those differences are, that we can better target interventions. So, summary of New York City, November 2013, we see that our infant mortality rate actually has not changed much since 2011, although we are at the lowest among the top 10 in the nation. We are not the best worldwide, are we? Right? We're not. We're somewhere in the middle, so that we shouldn't, applaud our successes yet, because we're not internationally where we should be. Since 2003, there has been a decline. The Take Care New York, which I shared with you, was a citywide infant mortality initiative, and looking at the Healthy People 2020. The leading causes of death, I think you know from your own communities, they're very similar. And our highest infant mortality rates remain in the poorest neighborhoods, so that attacking poverty, which happens to be the priority strategic issue for the American Academy of Pediatrics, we need to tackle that one to be able to impact. And disparities persist, and in fact, we need to continue to disaggregate the data and take a look at effective interventions. Our science needs to guide us, but it needs to guide us in implementation that is adapted to the communities, and that is embraced by communities, and that is changed by communities to make it relevant to them. I'm going to stop here. Oh, I guess the lessons here: consistent, sustained, iterative, right? PDSA cycles. Our community health indicators, we need to be proud of all of our communities. And I think I've touched on all of these. You've touched on many of these in your efforts. And again, I applaud you, the nurse-family partnership, home visitation, a number of things, and the fatality review, which I think is important. And then this dissemination of the public health approach. And it is beyond health. It is about our politics. It is about allocation of resources. It is about whether everyone has access to universal health care. Thanks.
So, Dr. Rock, thank you for that presentation. It does set the stage for what we're going to move into next, and you've covered quite a bit. You did it very well. And it's also a great sort of recap from a content perspective, and we all have been very interested in hearing about New York and how you did what you did. So, and thank you for coming and sharing. What we're going to do next, she talked about the perinatal regionalization. She talked a lot about self-sleep, and she sort of wrapped a bow around all of this. And one of the things I picked out is the persistency we have to have. You can't just get started, work on it 3 or 5 years, and say you're done. It's a never-ending story and never-ending work. So we want to have the task force members stay in your 2 groups. And what we're going to do is have the conversation facilitated around these issues. Sometimes we talk about safe sleep as low-hanging fruit, which, sort of gives you the impression it's easy to do, get it done, and you can move on the other things. But it's not easy fruit to pick, no matter how low we may think it's hanging. And this presentation sort of speaks to that. So there are 4 experts that we have in the room. I'm going to change things up on you guys and ask you to have a safe sleep group, and then we're going to have a group that talks about the perinatal regionalization, and then you're going to switch. We're actually going to let you switch this time. And we have Ed Shepard with Nationwide Children's Hospital. Where are you, Ed? Thank you. I should say Dr. Ed, if that's okay. He's with the neonatal group here. Shannon Ritchie. I know you, Shannon. Where is Shannon? Oh, there you are. Thank you. So Dr. Shepard and Shannon will talk about the perinatal regionalization with our half the group, and then we'll have the safe sleep discussion. Dr. LaRock will participate in that. And from a local perspective, I think it's going to be Jose Rodriguez. Is that right? Are you here, Jose? Perfect. And Jeff Klinger. Oh, there we go. Sorry. And Jeff Klinger. So where are you, Jeff? Thank you. Sorry about that. So what did I designate you guys as? Regionalization, safe sleep. Okay, regionalization, safe sleep. Facilitate for about 15 minutes, 10 to 5, yeah, and then we're going to switch. We'll let you know. Thank you. Yes. I know this is one of those topics that once you get started, you say, why are you making me stop? But what I'd like to do is ask each of your groups to just take one issue, one salient point that you've discussed with your experts and share it with the entire group. So I'm going to start with this group because that's going to put you on the spot. One salient point in your conversations, it can be on safe sleep or it can be on the regionalization, or you could talk about both. Yeah, I know, I'm pulling you back together. I hate to do that. I'm sorry. Is anyone in this group? I know there's a ton of things you're struggling with. Which topic? Well, use your microphone, Director Trotman.
Sure. Yeah, we just been a lot of conversation on safe sleep and the availability of a safe sleep environment. And we just learned that there's legislation pending to actually have safe sleep environments purchased by some of the hospitals before families leave. Did I get it right?
Make sure that we hook them up with a safe, whether we purchase them or hook them up with another foundation in the community that might provide that.
Okay. So to make sure the environment is available for families in need, because our question, we talk a lot about safe sleep, but is that environment available for certain families in these different settings that some of these families live in?
Good comment. Okay, our group here. safe sleep, regionalization, any one of those topics, salient points or issues that came out in your discussion? I know there were many.
I think we commented on the importance of finding ways to make sure that the information about safe sleep gets to all of our citizens, and some of the challenges and obstacles there are, particularly with those who are facing poverty.
Yeah. Very common themes. So I wish we could continue. We will, in a way, because this is the beginning of a journey. So this is a topic we will revisit again and again. Let's take a moment and thank our experts. I know they feel like they're learning, but we appreciate your time. I'm going to turn this over to Mike.
So Commissioner O'Grady had another meeting he had to get to, but he did ask me before he left one more time to also acknowledge Director Anthony Trotman for finding the money that the commissioners were able to vote on. Funding for this has not been easy, and the commissioners have been very generous. And John O'Grady made a point of saying, make sure you thank Anthony Trotman, because he's the guy that's finding the... So, Director of Jobs and Family Services, thank you very much. We appreciate it. So, as usual, another informative and productive meeting. It's always, it amazes me, I guess. You come here and you spend a few hours and you talk about things that you think you know, and you bring it into focus and you look at the statistics and you think, aha, if we could just do a little bit more of all the stuff that seems very natural to us, so babies sleeping on their backs and breastfeeding and all the stuff that we know is important, and we could get everybody thinking in the same way and doing the same thing, we could make a difference. So let me sum up some of the takeaways from today. We've had great improvement efforts underway in the clinical care arena, 17P, 39 weeks. We need to make sure that our plan recognizes that good work and support opportunities to improve and expand to physicians and eligible patients, as Steve mentioned, throughout this community. We've also identified potential opportunity for improving our system of perinatal services, in particular for high-risk women. I think we can all agree that we have the expertise within our health systems to look at where we are today and to come back with an assessment and, if necessary, recommend some changes for improvement. Lastly, we've had many great ideas for promoting infant safe sleep. We already have a lot going on in this community, but we need to make sure that we are coordinating and leveraging all those available resources in the various places that we talk and are able to teach safe sleep. Much of the current work occurring in the healthcare arena, perhaps there's opportunity to expand this messaging into other settings where it's not being messaged. I was particularly impressed, Donna and I talked a little bit about those impressive New York numbers and what they've been able to accomplish. You guys have done a great job there, and I know you're not satisfied, and we won't be satisfied when we move the needle either, but it's a goal for us to achieve what you've achieved. One way we can do all this as community leaders is to adopt image standards. And I know I plan, when I get back to my office, to talk to various folks at our television stations and in our various publications to see what we can do to advance the message. We talked in the beginning of the meeting that next month we'll learn from other communities that have successfully reduced their own infant mortality. We will have another guest from New York City, as well as from Baltimore, to talk about their initiatives and what's worked and what's been impactful for them. One of the best ways to illustrate the importance of our work is to see firsthand care for premature infants right here at Nationwide Children's in our own NICUs. So task force members, we're going to ask you to gather up your belongings, and Julie and Jesse are going to lead us on a tour of the NICU. Unfortunately, because of where we're heading off to, the size of the group, we have limitations on how many we can get through, so we're going to kind of get into small groups. And also, members of the public, if you're interested, we would also love to host you. Unfortunately, we're not going to be able to do it today because of the size of the group that we have here. So feel free to talk to some of the staff, and we'll figure out a time to get you back in. So thanks, everyone, and we look forward to seeing you at some of the upcoming community meetings.
This adjourns, and we won't be coming back.
It's our meeting. We won't come back here.